Teens families, thank you for being here. My name is Heidi Sauer. I am the Director of Counseling for the district, and I'm pleased to welcome Dr. Kristin Kroll tonight. She is a licensed psychologist with a wealth of experience in family behavioral health. She's worked with renowned institutions such as the Children's Wisconsin and Medical College of Wisconsin, where she developed quality improvement initiatives focused on preventing suicide. She also earned over $190,000 in grant funding, has presented or served on panels for over 15 national and international conferences. She's published a total of 14 peer-reviewed journal articles and book chapters, and she also has published books. She's the owner of a virtual psychology practice that's based here in Westlake called Little Dove Consulting, which provides virtual psychotherapy for children, adolescents, and adults. And most importantly, she is a proud parent of a Mustang who has started kindergarten this year.
Yes, we're definitely. That's the best part. Well, thank you guys for taking your time. I know this is a weekday night. We're all tired and we're getting dinner ready. So thanks for taking the time today. Given that we have a small group, what I'd really love to do is make this as interactive as possible. And that if you have a question or I want more description about what we're talking about, you can either just unmute yourself, speak up, or write in the chat, and Heidi will help monitor that for me. But really want to make sure that you get the most bang for your buck and get your questions answered today, or at least I can at least point you in the right direction if you have a specific concern that brought you to this meeting tonight. I'm going to go ahead and share my screen here. Okay, so today we're talking about supporting the mental health of your preteen/teenager. And, I really wanted to highlight the preteen stage as well as kind of the adolescent stage that we talk about, because as we're looking at the research, we're seeing that mental health concerns are starting earlier and earlier. And so really wanting to make sure we get ahead of the game of knowing kind of what are some early warning signs that can start very young, as well as how do we do some preventative work before your teenager gets older as well, to try to do what we can to keep everybody in their best mental health. So Heidi did me the honor of talking about some of my accomplishments. You're feel free. I'm not going to go through them again. You guys had to sit through that. But basically, it is up to you whether you decide it is worth listening to me or not. I welcome all questions, comments throughout this presentation. So please feel free to interrupt throughout this. I don't want to be just preaching here for an hour. I would say most of my work has been in pediatric psychology, which spans from prenatal diagnosis. I worked with medical concerns where there was a prenatal diagnosis, all the way up to about age 27, when kids are kicked off their parents' insurance. So that is the clinical population I'm privileged to serve. All right, so let's get into it. So the agenda today are just talking about kind of what is child mental health? What are the child and adolescent mental health concerns? What are some common mental health concerns that we see in children and adolescents, especially now in the last couple of years? Unfortunately, one of the things that I wanted to make sure to really talk about today is suicidal thoughts and suicidal behavior. What are the warning signs and what to ask if you are concerned about your child? What are some of the more frequently asked questions I'm asked by parents and caregivers? I just wanted to kind of hit some highlights to see if that might answer some questions that might have brought y'all here today. And then what are some local resources should you have any concerns for your child, or just wanting to make sure that you've got all your ducks in a row should a concern present itself later on. Okay, so what are mental health concerns and how are they diagnosed? And so the biggest thing about mental health concerns are we're looking at symptoms that really show a degree of distress, emotional distress, that's more than would be expected for that person in that situation, a higher degree of impairment, so functional impairment, such as impairment in social functioning, academic functioning, impairment with their family relationships. So any types of symptoms that are causing distress or impairment that are culturally atypical. So making sure that whatever symptoms or behavior we're exhibiting is consistent with what we would expect culturally. Symptoms that are developmentally atypical. So for example, I'm just now have gotten out of the temper tantrum stage with my daughter now that we're entering kindergarten. And so when we're talking about developmentally atypical, are the behaviors that are being expressed by that patient typical for their age or not? So a 3-year-old having a temper tantrum, developmentally typical, not concerned. A 6 or 7-year-old having a temper tantrum, a little bit developmentally atypical. So that's where we really want to hone in on, is this a concern for what we would expect for the development? And is the distress, impairment, developmental atypical symptoms, are they not accounted for by other factors such as medical concerns, substance use, or another diagnosis? So for example, if I have a child, an adolescent, usually a adolescent or young adult presenting with depressive symptoms, one of the things I want to be on the lookout for are, do we have a family history of hypothyroidism? Or if we have a child presenting with a new onset of OCD, have they recently had a strep infection, which could be associated with a PANDAS concern? And so, are we seeing some of these symptoms? Are they related to medical factors, substance use, or some other concern? So, what are the concerns? And do they make sense given the patient's age and presentation? We're going to review kind of the more common treatments for mental health concerns. And by common, I want to be really specific. By common, I mean the most evidence-based treatment for specific mental health concerns. One thing I want everybody to walk away with today is knowing what to look for if they pursue counseling or medication for their child. Because, just like any profession, we have a range of people who are novice to experts in their field, and making sure that you're able to find someone who's a good fit for your family, can provide the evidence-based treatment. With psychotherapy, we'll be talking today, some of the most evidence-based treatment for children and adolescents is cognitive behavioral therapy, interpersonal therapy, specific for depression, and family systems therapy, which is used a lot with conduct disorder and oppositional defiant disorder. Most commonly hear me talk about cognitive behavioral therapy, since that's traditionally what's used with work in ADHD, anxiety, and depression. In therapy, we talk about, the different setting, the modality of telemedicine versus in-person. My practice, I chose to make a telemedicine clinic, and that's because I know with the research that we have, especially since COVID, is that telemedicine for psychotherapy is as effective as in-person for almost all conditions. The few conditions where I'd say, no, you really need to go in person is if there's a severe developmental disability or autism, some severe autism is a main presenting concern, just because those evidence-based treatments need more of that face-to-face work. We'll talk about psychotropic medication, just a fancy word for the Zolofts and the Prozacs and other medications that can be used as part of treatment. I'll be talking a lot about physical activity and how that is an overlooked treatment for mental health concerns for both pediatrics and adults. Phototherapy, and then complementary and alternative medicine will be mentioned as well. Okay, so let's delve in, and Heidi, I'll have you just monitor the chat for me. I'm going to keep going. The most common pediatric mental health concerns, pediatric meaning childhood, early school age, and adolescence. In the US between 2016 and 2019, the most predominant is ADHD. And ADHD, we've gotten more traction from the 90s of people being more aware of what the symptoms can look like. And ADHD is one we'll explore a little bit more in depth, since it is so common and it has so many different presentations. ADHD is one of the few disorders which is more common in males. So we see this a bit more in boys than females. Anxiety, also very high at 9.4%. Is the prevalence rate, tends to be a little bit higher in our gals. Behavior problems, behavior problems is not a diagnosis. Behavioral problems is a symptom of a diagnosis typically. But we wanted to, because it's such a high correlate, we wanted to highlight the behavior problems is another main concern when people present for mental health treatment. And then depression at 4.4%, which is, again, hits females a little bit more with regard to risk ratios than males. Okay, comorbidity of diagnoses. Now here's where I get to nerd out, so just hang with me here. And so major depression is kind of the classic episode of depression that we see with depressed mood, changes in sleeping and eating, feelings of hopelessness, helplessness. And then dysthymic disorder is kind of a low-level depression that lasts a long time. So I kind of call this my Eeyore, where we have a kiddo who's just kind of sad and mopey and has been that way for a while. That's more of a persistent depressive disorder. And the reason I highlight this is a lot of times we'll have I'll have a patient referred for behavioral concerns or anxiety, when underneath is also either depression or comorbid with it, which means occurring at the same time as depression. So you can see here, if we have, if a child is diagnosed with major depression, 34% of those kids will also meet criteria for ADHD. 30%, which may also include some of the kiddos with ADHD, would meet criteria for ODD, oppositional defiant disorder, and so on for generalized anxiety disorder and conduct disorder. And so a lot of times what I want to make sure is, especially if your child is having behavioral concerns, is really trying to see, is the behavior a symptom of depression, or is it truly a behavior we have to get kind of the reinforcement and consequences into place? Same thing here, dysthymic disorder, you see, 63% of kiddos with dysthymic disorder, that kind of persistent depressive state, being diagnosed with ADHD. And so it's really just trying to keep in mind, if you have a child with a diagnosis, is let's keep an eye on what other symptoms might be occurring and maybe contributing to how they're presenting. All right, so let's delve into ADHD. In the 80s and 90s, this used to be called ADD and ADHD. ADD, attention deficit disorder, referred to the inattentive type. Now we just call it, collectively ADHD, and we have different subtypes. We have the hyperactive subtype, the inattentive subtype, which was the ADD, and then we have the combined subtype, which means they meet criteria for both inattentive and hyperactive. And you see here kind of the classical symptoms of fidgeting, talking a lot, restless, frequently interrupting. And then we have the inattentive type of kind of just trouble following instructions, difficulty staying organized. We'll see a lot of the kiddos with the inattentive type will never remember to bring home their homework, or they'll forget that the paper is due. And so kind of that forgetfulness. Now, what's interesting about ADHD is it's one of the few pediatric diagnoses that part of the population the symptoms will resolve on its own. So for example, when we look at research kind of longitudinally about ADHD, about 50% of kids diagnosed with ADHD in childhood will no longer meet criteria as an adult. And whether that's the result of, better coping skills, or them finding job placements or careers where it's a better fit for their personality and what their strengths and weaknesses are, there's some debate there. But it's something to just keep in mind that, that's why we really want to work on organizational skills and things like that, because ADHD can remit as the child gets older. And for other kiddos where it's more just kind of genetically hardwired, this is how they were made. We can look at, psychotherapy, medication, and time. Here was my reference to time of, that some of these cases will remit over time. For ADHD treatment, if I have a child with mild ADHD, I'm going to start out with psychotherapy first. I'm wanting to work more on, social skills training is a big one. A lot of time kiddos with ADHD, because of the impulsivity, they might have trouble with friendships because they might talk over or, cut in line and things like that. So a lot of times we'll work on social skills training. Other times we're working more in parent training and behavior modification. So for example, I have a patient who wouldn't stay seated in the classroom. And so what we ended up doing was having a daily report card where every day the teacher would put a check or an X, whether they had stayed in their seat for X amount of minutes in that class. And then when they got home, the parent provided the contingent consequence. Contingent meaning what they received as a result of their behavior. So they received, 15 minutes extra TV time or 15 minutes less TV time based on how they had done at school that day. So we had just kind of applying consistently, rewards and consequences to help shape behavior, social skills training, and then cognitive behavioral therapy as well. So if we have a kiddo who's having trouble, staying seated, coming up with a plan for, increasing physical activity during the day to burn some energy off, or, what are some relaxation skills they can do internally when they're having trouble sitting still. Medication with ADHD for moderate to severe, I really like to include that as part of the treatment plan, just because there is that genetic hardwiring component for a lot of those kiddos. And so we have typically 2 classes. And again, I'm a PhD, not an MD. So any medications I reference are, I'll defer to your medication prescribers. I'll just say what's in the research literature. But typically we're looking at stimulant medications such as Ritalin, or non-stimulant medications such as Strattera. So I used to work with, at Children's Hospital Wisconsin, pediatric heart transplant. And with pediatric heart transplant, there is a bigger risk for executive functioning deficits which means, a higher rates of ADHD. And because of their cardiac problems, the stimulant medications were an option. So we were working closely with doctors so that they could treat the ADHD with a non-stimulant, and making sure that their heart was in good health. And so if you have a child with complex medical needs, such as a severe congenital heart defect, diabetes, things like that, and we are looking at psychiatric treatment, I'd always push for someone to go to a child psychologist with specialization in it. Otherwise, for kiddos with typical medical presenting concerns, no significant severe concerns, a lot of times I'm going to recommend treatment starting with their pediatrician, as long as they're well versed in the research literature, just because there is such a long wait for child psychiatrists. So for ADHD, we're looking at psychotherapy. These are the more evidence-based treatments, psychiatric medication, time, and one I did not put on here, which I'm very surprised at, is exercise. So, physical activity is really key, especially if we have a hyperactive kiddo. Is the subtype, is really having regular physical activity, ideally in the morning. But I know with my own child, trying to get them up early and getting them to not work out, but to go for a walk before school may or may not be feasible. So any physical activity at any time of day is better than none. Okay, any questions here, Heidi, or should I keep on going here?
You can keep on going. No questions yet.
All right, I'm going to just assume it's that good. I'm just going to assume it's that good now that everybody's logged off. So next we're going to move from ADHD into anxiety. Now I want to be really careful here in that when we talk about anxiety, there are a lot of different subtypes. So we have specific phobias. So for example, that's if a child got bit by a dog and then they have kind of a phobic response to dogs where they, can't go to a dog park without having a panic attack, or even, walking near a dog is anxiety provoking for them. Then we have social anxiety disorder. Social anxiety disorder, typically more common in females. You see it usually starting pretty early on. It kind of tends to be a temperament, a trait, something that you kind of have that tendency throughout childhood, and it just tends to worsen with time unless we really are focused on exposing them to social activities. So the specific phobia is usually in response to a specific, fairly traumatic event. Social anxiety disorder, usually you start seeing pretty early on. It's just kind of a temperament. And, we just want to make sure we really are working on that earlier rather than later. Separation anxiety disorder. This is, again, I want to go back to my point about developmentally typical or not. So separation anxiety disorder is actually a good sign. The separation anxiety is actually a healthy sign of attachment when you have a kiddo that's, 1.5 to 3 years old. That anxiety when they're separated from their primary caregiver is a sign of, a healthy, strong, secure attachment. Problem is if that anxiety continues as they reach 5, 6, 7, 8, then we're starting to look at more of, okay, we should dedicate some time to treating this and helping them work through that anxiety. Panic disorder, this one is a little bit higher in males than females, actually. But panic disorder is when, there's a certain event or situation that spurs on a panic attack, which has the real classic, somatic symptoms of feeling like their heart is racing, that their throat's closing up, that they're breathing really fast, that they're going to faint, things like that. And so when a kiddo has a panic attack, a lot of times their parents are well-meaning and are scared and will take them to the ER because they're worried about a heart concern. When in all actuality, they do the screening and most of the time it comes out as a panic attack. The agoraphobia comes in when someone has a panic attack, is scared of it happening again, and starts avoiding places where they had the attack. So if we have a child who has a panic attack in the lunchroom, for example, the agoraphobia would be avoiding the lunchroom, or refusing to go to school because they're trying to avoid what had triggered the fear in the first place. And then lastly, I have to say this might be my favorite disorder to work with, the generalized anxiety disorder. And these are the kiddos who are just the natural born worriers. They typically have worries about common everyday fears. They're just exaggerated a little bit more heightened. So we tend to have a bit perfectionistic tendencies with generalized anxiety disorder, kiddos who are really striving to do well and are a little bit too hard on themselves if they don't meet their expectations. So these are my little worriers. who are kind of born that way, and it has become a double-edged sword for them. It can be one of their biggest strengths in that they'll worry about tests and they study more, but it's also, something they struggle with because it's hard on them to have such high expectations and feel so anxious. So for anxiety treatment, I'm going to break it down a little bit. So the umbrella term for the most effective anxiety treatment is cognitive behavioral therapy. If we're looking at something like a panic disorder, a phobia, even social anxiety disorder, we really want to narrow in on something called exposure therapy. And simply put, it is just exposing someone to their fear over and over so that their body stops having such a heightened startle reflex, heightened physiological response. So for example, if I was doing exposure therapy with a kiddo who had gotten bit by a dog, what I would do is start with an exposure of having them do breathing techniques while we talked about dogs, then having them do breathing techniques while we looked at pictures of dogs, then doing breathing techniques while we walk within 20 feet of a dog park. Then the next week we'd go in a little closer. And so slowly exposing yourself to the anxiety-provoking stimulus over time. And at the core of anxiety treatment, it's exposure therapy. Different ways of packaging it, but the exposure therapy is really the key part of anxiety treatment. The worst thing, and there's a lot of parent education, because one of the worst things that we can do for anxiety is to reinforce it by allowing someone to avoid what's scaring them. So, oh, honey, you're scared of dogs. No, we won't walk on that street because that's where a dog is. So avoiding the things that scare them. And so really not doing that accommodation of feeding into that child's avoidance because you don't want them to be distressed. It's counterintuitive, but we are actually wanting to put them in situations where they are distressed so that their body habituates and it becomes less anxiety provoking over time. Anxiety treatments are some of our most effective treatments for mental health. It can be very tough because it's hard to, have your child stay in a difficult situation, but it is one of the most effective things we can do with our mental health treatment. For some of our kiddos, especially my little worriers, who that's just how they were made, sometimes, we start with cognitive behavioral therapy. It may be a good idea to do a combined treatment of medication as well as psychotherapy. Typically for anxiety and depression in pediatrics, we're looking at an SSRI, most likely a Prozac, a Zoloft, are the two main ones that have been FDA approved for pediatric anxiety. And one thing I always like to mention is physical activity, regular exercise, especially if I have, usually it's my teenage boys who are not a fan of therapy, but if they really don't want to come to therapy, one of the best things they can do is have that regular exercise. Because, I don't want to put myself out of business here, but when we look at treating anxiety and depression, the effectiveness of cognitive behavioral therapy is equal to the effectiveness of psychiatric medication, the SSRIs, which is as effective as physical activity. And so if the gold standard is to combine all three, and those are our three best treatments for anxiety and depression for both pediatrics and adults. But if I have a child who the family really is just against medication, it's not within their belief system, no problem. We need to at least be doing the therapy and physical activity. Same thing if I have a teenage boy who is not going to do therapy, will not do it. Then if we're looking at medication, we also need to add on the physical activity as well. Okay, I'm going to keep going here. Behavioral disorders, I always put quotes on that because I want to really emphasize typically the behavior is a symptom of something else. So for example, I usually see behavioral concerns when there's anxiety. So they're acting out to try to go home from school. I'll see behavioral disorders when there's depression, because what's different from a adult presentation of depression is children can present with either like a depressed mood or irritability. So they may or may not present with sadness and a depressed mood. They may just present with irritability. So if you have a child with significant increase in irritability, I want to be checking out for depression first thing before I leap to irritability and behavioral concerns. So with our behavioral disorders, we're looking at, okay, is the behavior developmentally appropriate? And I'll reference back to my temper tantrums, with the little kiddos, that's developmentally appropriate. Or are we seeing what appears to be a temper tantrum in a teenager? Is the intensity of the behavioral concern appropriate for the situation and the age of the child? Is the frequency appropriate, or I should say typical? Let's keep it to the word typical. Severity and duration. So how long are these behavioral concerns lasting, and are they typical for the age or not? And if they aren't, we want to definitely scan for the other concerns that might be masked by the behavior, such as anxiety, depression, ADHD. I see a lot of kids who quote unquote act out because they feel like they can't understand or they can't keep up academically, so why try? And they get bored and act out, when what it might be is a learning disability or ADHD that hasn't been treated. There are times when it's a true behavioral disorder, such as oppositional defiant disorder and conduct disorder, but those are the diagnoses we go to last, because we really want to rule out when the majority of concerns are anxiety, depression, things like that, social skills. So, as I was talking about before, the behavior, really want to look at the etiology of concern, what's underneath it. So we know that a lot of kids will be acting out or having behavioral concerns when there's a lot of parental stress, when the family environment is high in, kind of drama, and we call it high EE, high expressed emotion, loud voices, yelling, dramatic exits and entrances, the real dramatic family presentation or family dynamics, it typically can be seen as a risk factor for behavioral kind of acting out. And so that's why when we look at parent stress, one of the things when I talked about being a pediatric psychologist of working from prenatal to age 27, a lot of times when we're looking at, parents and, child mental health, especially in the early years, the target of focus is the parent mental health. So I told you I worked with congenital heart disease, and there were some really hallmark studies that were done that when parent stress was measured prenatally in mothers in particular, in dads too, but really I think the survey was, or not the survey, the RCT was with mothers. The parent stress was predictive of the child's overall adjustment and emotional coping at ages 1, 2, 3, and 4, more than the severity of the medical concern. So, for example, I had families who were waiting for a heart transplant, and their child was coping better than a child with a slight heart murmur. And a lot of that was due to how was the parent coping through, no fault of their own. It's a stressful situation, but that parent stress and making sure the parent's mental health is doing okay is probably one of the best things we can do to help child mental health. So continuing with behavior, we've got kind of family dynamics and risk factors. We've got underlying concern. Are we acting out to avoid something at school because we're anxious? Has there been a trauma and that we're acting out as an expression of that trauma? Grief, depression, you name it, so really seeing the behavior as a symptom. We have additive effects of, we have a higher risk of behavioral concerns when a child has cognitive deficits due to, trouble with some processing or being able to communicate. So a lot of times we, want to be aware of that if there are some cognitive deficits and how that might be impacting behavior. We also have temperament playing a role. We just sometimes have kiddos who are a little bit more high strung, a little bit more aggressive, and that's just a part of temperament. I like to always think of this as a strength and a weakness, just like anxiety. And then we have, I hate to say poor parenting skills, but I'll say ineffective parenting skills, where we're all trying to do our best. But for example, one of the things that comes to mind when I think about behavioral concerns is corporal punishment. Now, I grew up in Georgia. My family's from West Virginia and Kentucky. Culturally, not in my primary family, but culturally, corporal punishment was an acceptable form of, helping with child discipline. The problem is when we look at like the actual research of, is it effective or, does it help? We've seen that corporal punishment, even if it does not meet the criteria of child abuse, is associated with more aggressive behavior than if a timeout or something else was implemented. And so I always just say, not only, I don't believe in corporal punishment personally, but if we're looking at just, is it effective? It's probably one of the worst things we can do with regard to how it heightens aggressive behavior. So when we're looking at parenting skills, a lot of behavioral treatments for especially kiddos who are younger in that 0 to 5 range, it's working with parents on implementing appropriate timeouts, giving positive reinforcement more than negative reinforcement, and really trying to make sure that we're using some healthy parenting practices. Okay, I'm gonna take a sip of water. No questions. Giving y'all a second, but I'll just go ahead and take a break for a second here. So treatment for behavioral concern, again, it goes back to the underlying etiology or cause. So if we're having a family high, has had like a lot of chaos in the family, there's been a lot of transitions or changes, we might be looking at more of family systems therapy, just helping to repair dynamics, help with parent and child communication. If it's more that the disruptive behavior is due to depression, trauma, anxiety, we want to do an evidence-based CBT for that. Otherwise, sometimes it can be the psychiatric services with medication. If there's an untreated severe ADHD or another concern that would be best served by therapy and medication. You'll see here, I always highlight the marital or individual parent counseling, just because we know that parents' mental health really plays a role not only on the child's self-esteem, but also on just their externalizing behavior. So how they could act out as a result of the stress they're feeling in their own environment. And then parenting training, parent management training is actually great for most ages. I think like 3 to 18, you can use parent management training. Parent management training is also one of the most evidence-based treatments for ADHD when the child is 5 and under, because at 5 and under, it's really working with the parents and helping them teach their child to self-soothe and when to apply reinforcement for appropriate behavior versus undesirable behavioral. We also have PCIT, which usually can be freely accessed through the state. That's another good one, as well as the P positive parenting program. So if I'm looking for help with parenting, and I'm looking at different resources in the state or with a private practitioner, I'm really wanting to see that they're basing it off on one of these three as some of the more evidence-based parenting training practices. Okay, depression. So depression, as I mentioned before, we have kind of the classic symptoms of depression here, with the depressed mood most of the day, nearly every day, and the time period is 2 weeks. We usually keep it within these symptoms have to have occurred for at least 2 weeks. The biggest difference here is in children and adolescents, this could be an irritable mood. I will say with my boys, I'm typically seeing more of an irritable presentation versus a sad presentation. Diminished interest or pleasure in almost all or almost all activities. So they stop wanting to go hang out with their friends after school. They stop wanting to go to soccer practice. Changes in weight, to significant changes in appetite. So we're just looking for changes in appetite, weight, sleep, all of those kind of vegetative symptoms of depression. Changes in how they present with regard to their energy level. So are they moving more slowly than they typically, talking more slowly, or are they kind of hyped up? They're just more energetic than usual. There's a big change there. Feeling fatigued, feelings of worthlessness or excessive or inappropriate guilt, trouble thinking and difficulty with concentration or indecisiveness. And so if I have a kid referred to me for ADHD, I want to check and make sure that difficulty concentrating is not due to depression before I jump to ADHD, because a lot of these symptoms can mimic others. And then, of course, I want to normalize that suicidal ideation, kind of that morbid thoughts about death, are a classic symptom of depression in pediatrics as well as adults. So treatment for depression, the psychotherapy or talk therapy, classic cognitive behavioral therapy, where we're working on specifically cognitive restructuring. So if we have an automatic negative thought, how do we restructure it so that it's more realistic and appropriate to the situation? It's not just our depression taking control of our thoughts and twisting them. Behavioral activation, which is a very simple, kind of hard to implement, of really just getting people on a regular activity so that they are moving and achieving both goals that are valued as well as pleasurable. So I see a lot of this in the summertime, where some kids who do well during the school year struggle with depression during the summer because they're off schedule. They're not feeling like they're achieving anything. They're kind of laying around a lot. And so I see a lot of moods go down in the summer when we have to get everybody back on a schedule, achieving, and again, it's achieving goals that are both, there's value in it. They feel proud, as well as pleasurable activities as well. I'm a big CBT component, but I would be remiss if I didn't say that interpersonal therapy, which is a different paradigm for treating depression, depression has also been found to be very effective for depression in adults and adolescents. Psychiatric medication for more of the severe cases of depression. We're looking at SSRIs and others as well. Now, when we talk about SSRIs, I don't want to give a quick plug because I know growing up in the 90s, there was always the black box warning came out, and everybody was scared to get on to put their child on an SSRI, because what they had found was a few select cases where a child was put on an SSRI and later they attempted or committed suicide. The problem is, when we look at the research now that people have been on these things for decades, what we know is that some of those children and adolescents, when they were put on an SSRI, it helped them have more energy. So if they had been planning on committing suicide, they were actually able to carry out the plan they had already made. The research is really showing that black box warning did more of a disservice than anything else, and that we feel like the research is really showing. A study just came out, I want to say a couple months ago, showing that we feel like the rates of suicide attempts are much higher because people were scared to put their child on an SSRI to manage the depression because of that black box warning. And so there's a lot of debate in the literature and in the academic world right now about whether it's time to remove that black box warning. So just a little plug, if with medications, everybody has to come to their own decision about the appropriateness. But if I have a severely depressed child or adolescent, I'm wanting to do the gold standard of the combination of the psychotherapy and the medication for start, as well as the physical activity and exercise. Now, the light exposure, I wanted to bring that up because sometimes we have something called the seasonal pattern of depression, what we used to call seasonal affective disorder. And so if your child or adolescent around October, November, December, their mood starts coming down and they start eating more carbohydrates, sleeping more, kind of like they're hibernating. And then their mood starts perking up around March and April when the seasons are starting to shift. We might be looking at more of a seasonal pattern of depression. And so one of the more evidence-based treatments, if that's the presentation, is something called phototherapy, which is that light exposure. And that can be accomplished with morning light, trying to get out in the early morning, or specific lamps that are 10,000 lux that you use 20 minutes a day that actually help activate the brain for cases for patients with seasonal depression. Has not been found effective to help with typical depression, but it does help if there's a seasonal pattern to it. Okay, so we've talked about depression. So let's go ahead and just delve right into, adolescent suicidality. And, I'm sure a lot of people, that's a concern. And that's part of the work I do with Children's Wisconsin now, is because that's become such a pressing concern over time, especially since the pandemic. When we look at numbers from 2018 to 2019, adolescents between ages 12 to 17, 18 and 19% had seriously committed suicide, seriously considered suicide. 16% had made a suicide plan. 8.9% had attempted suicide within that span. 2.5% had made a suicide attempt, which required medical intervention. So urgent care, ER, because of the severity of their attempt. Some of the warning signs I really want to highlight. Now, these are just kind of the standard warning signs. We've got the suicidal threats, suicide plans, making final arrangements. The ones I want to really key in here are the sudden changes in appearance is a big one. So if I have a child whose hygiene has gone down, they're not bathing, they're not wearing deodorant, and that's a change for them, I want to really pay close attention to them. Now, if they're like that 5th or 6th grader who hasn't gotten used to wearing deodorant yet, that's another thing. But if there's been a bit significant change in grooming and hygiene, I want to really touch base with that child and see what's going on. A lot of changes with sleep difficulties, especially trouble falling asleep or that early morning awakening and not being able to go back to sleep. This perceived burdensomeness, I want to really highlight the hopelessness, helplessness, and perceived burdensomeness. So some people who work with, who really specialize in the research on suicidality we'll actually do something called the Beck Depression Inventory, which assesses suicide and depression, or the Beck Hopelessness Inventory. And because we know that feelings of hopelessness are such a key factor and predictor of whether someone might attempt suicide. So when I hear someone who's talking about feeling hopeless or helpless, or that they perceive themselves as a burden, that's when I really want to cue in more so than even some of these other classic symptoms of suicidality. Because, suicide threats, suicide plan, making final arrangements, all of these are very important. But that hopelessness, helplessness is what I really want to cue in on as a parent. So what to do in a crisis? So if you're a parent and you are, worried about your child, or they've come to you, or they've attempted, the biggest thing is trying to remain calm and ensure that someone stays with the child or adolescent until you're able to secure safety. So for example, if you have a child who says, I'm feeling suicidal, what you're wanting to do is to make sure to stay in the room with that child until you're able to take them to the ER or to a mental health urgent care. The biggest thing is staying with them and restricting access to lethal means. So, for example, if the more common situation I face is when I have a patient who's having thoughts of suicide, is talking about it, which is great. We don't think that they need inpatient hospitalization. They're not an imminent risk, but they're feeling down. They're having suicidal thoughts popping up and they're having trouble managing it. What I want in that household is I want all the prescription medications, and I want all the over-the-counter medications, especially like the Tylenol and ibuprofen, locked away so that there is no access for the child. Same thing with guns, of course. I want those locked up, and knives. Just because, I need to come up with a better analogy for this, but if we have someone who struggles with alcoholism, we wouldn't keep a 6-pack of beer in the fridge. Same thing if we're having an adolescent who's struggling with thoughts of suicide, we don't want to have something that's easy for them to grab impulsively and use. We really want to restrict access to lethal means, because in that crisis, we're really wanting to slow things down and put barriers in their way before they can act on a plan. And I think the biggest thing is, if you're really concerned, we're in a crisis, the child, you can't get a hold of their pediatrician, you can't get a hold of their psychologist, and there's a crisis, go ahead, either calling 911 or taking to the ER for an evaluation. And that's just to make sure that we're safe for the situation while we figure out kind of what's the follow-up planning here. Okay, I'm gonna pause there for a second. Any questions there, or should I keep on going?
So far, I'm not seeing any questions in the Q&A.
Okay, all right. Well, y'all keeping me on track then. So some of the more common concerns when I'm working with my school age and adolescent kiddos and families is how and when do I talk about death and dying, sex, suicide? What do I do if my teen exhibits self-injury or low self-esteem? So I'm going to run through these and just kind of give some general things. So with regard to sex, I'm coming at this not from my personal values, not from, identify as Episcopalian, but I'm not coming at it from the Episcopalian. I'm not coming at it from anything other than looking at the clinical research. So whatever I say is coming from the research. You have to do what's right for your family and your values. When we look at what helps prevent teenagers or young people from having not just sex, so we're not looking, not focused on preventing sexual activity, but preventing sexual activity at a very young age or unsafe sex. What we found in the research literature is providing accurate information is really crucial, of making sure they understand, what can lead to pregnancy, what can lead to STDs versus just assuming they know. Being okay with knowing that teens can understand complex messages. And so, for example, I plan on having this conversation with my daughter when she's older. God help me, I'm not looking forward to it. But I don't agree with you having sex at this young age, or whatever age it is. Whatever age it is, I think it's too young. I don't agree with you doing this, but if this is something you choose to do, here's what I want to make sure you do to be safe. And so some parents might feel that, talking about condoms and birth control is saying that you approve of it. And the thing that we know with research is that the teen's going to understand complex messages of, I don't agree with this behavior. And if you do it, you need to be safe. That there's not a but, that those are two separate complex statements that can share the same space. Talking early. Unfortunately, we look at kind of when kids learn about sex and where they get a lot of the myths and misconceptions is because they learned about it early from TV, friends, cousins, you name it. They talk, and parents don't want to have that talk until they think, oh, when they start their period, it's when it's time to talk. That's a little late. We don't want them starting their period and then learning about sex. We want to kind of have this as an ongoing dialogue when they're earlier to help normalize it, make it okay to talk about, and make sure they know what to expect when it kind of comes to puberty development and how to keep themselves safe as they get older. The more conversations decrease risky behavior. So it's not that talking about sex will increase the risk that they'll act on it. It actually decreases the chance of them having risky behavior. Important, don't underestimate their current activity when they're a pre-adolescent or an adolescent. It's always good to overshoot and have these conversations a little too early than a little too late. And I think when parents ask me, well, how do I bring this up without making it super awkward? Look for openers. And I think back about, movies we watch as a family where there's like that weird, awkward sex scene that comes up that, we turn it off, or going ahead and pausing it and saying, and maybe not in that moment, but maybe the next day at breakfast saying like, hey, I know that was super awkward with the movie, but can we talk about this? I want to make sure you understand what this means. And, just want to make sure answer any questions you have. So kind of look for those natural openers. Death and dying. This is a big one that comes up, unfortunately, because that's a part of life. We have, especially for my younger kiddos, really providing simple details, matter of fact details, and not saying, I'll give you an example. We had a 16-year-old pug that passed a couple months ago. And so I wanted to say, oh, Roxy went to heaven. But what I forced myself to say was, Roxy's heart stopped beating. She died. And now she's in heaven. That's kind of for my family values, but being very clear that she's dead. She's not coming back on earth. Because there's a lot of magical thinking with those younger kiddos, and even in that early adolescence of, will they come back, or, were they just sick? And so when I've heard families say like, oh, your grandpa was sick and died. It was sick, and now he's in heaven. There's kind of that there. A lot of times I've seen kind of a phobic response of getting sick. Like that means you're going to die and go to heaven, versus saying his heart stopped beating, the lungs stopped working, kind of being very matter of fact and spelling it out simply. Using really direct wording, using the word dead, died, as hard as it is to say, versus passed away. And I think it goes without saying, ensuring that they know it's not their fault, just because there is a lot of magical thinking with some of these school age kiddos of, well, because I didn't do X today, that my grandpa got sick. And so if I do that again, someone else is going to get sick and die. So making sure that they're very clear about there not being a connection between their behavior and the death. If your child is attending the funeral, or their teenager is attending the funeral, especially if it's the first time, kind of explain beforehand what they're going to see. You're going to see grandpa in a casket. His skin might look a little funny because his skin will look a little white. You might see grandma crying the whole time. That's okay. Nothing for you to worry about. That's just her grieving process. And almost illustrating with your words what they're going to see before they enter in. Because they're going to be kind of coming in without any preconception of what to expect. And that can be very frightening. So trying to explain that, no, this is normal, that grandpa looks a little different, or that grandma is crying in the corner and you've never seen her cry. So really trying to illustrate what to expect. Goes without saying, telling them they are loved. I have a lot of people saying, well, my child's not talking a lot about grandpa. Should I be bringing it up? And I think the biggest thing is allowing room for questions, but not forcing the issue. And so I think one of the best things we can do is, if you, for example, something reminded you of grandpa, that you saying out loud, oh, this reminds me, Timmy of grandpa. What do you think? And then leaving it at that, so that they know that it's safe to talk about, that you're thinking about it and you're able to talk about it, but you're not forcing it as well. And if the child's up for it, especially if they're not attending a funeral, is a memory activity of, either finding pictures of their grandfather, or even just talking about their favorite memories. Some sort of closure activity is very important. With suicide, we talked about early warning signs. I think talking about suicide before a child is at risk. So starting, I hate to say it, even in, 5th grade, 6th grade is when I really want to start talking about, what suicide is. what do you do if a friend tells you they're having thoughts of suicide? What do you do if you start having these thoughts? And just talking about it early, especially if there's an opener such as, I forget sounds very callous of me. There was a One Direction member who recently passed, and there was a concern about whether it was suicide or not. I don't understand, exactly the circumstances, but the important thing is if other teens are perceiving that as suicidal, there's the risk of suicide contagion. So there's an increased risk when someone they know has committed suicide, or even a celebrity. When Robin Williams committed suicide or completed suicide, there was a significant increase in suicidality in certain populations. And so when we have a celebrity complete suicide, or someone in their peer group, we want to keep a little bit of a closer eye. We want to always normalize suicidal thoughts. Does not make them bad or crazy. It is a symptom, nothing more. A classic symptom of depression, trauma, you name it. I like to always, when I'm talking with a patient, and how I plan to talk to my child when I bring this up when she's a bit older, is looking at suicidal thoughts on a continuum of the kind of the low passive thoughts of, oh, I wish if I didn't wake up tomorrow, I'd be okay with that, all the way to those active thoughts of suicide of, I'm tired of living, I'm going to kill myself. And so when you're introducing that conversation with your child or adolescent, saying, hey, you know what, buddy, we can all have really dark thoughts, especially when we're stressed. And, it's common for these thoughts to kind of pop up. And so can you tell me kind of, have you had any thoughts where you just didn't want to wake up, or you just didn't want to be here, all the way to, I want to kill myself? Have you had any thoughts on this whole barometer? Or sometimes I'll even pull out a picture of a thermometer for my younger kids who are starting to show some concerning signs. And so it's not just black or white, you're suicidal, you're not suicidal. Just saying, what are some dark thoughts, and have they ever reached the point of wanting to kill yourself? And, just kind of having that conversation and making it as normal as possible, because it is a normal facet of human health and human mental health. And emphasizing it as a symptom, not that they're crazy or something's wrong with them, but that's just a symptom, nothing different. Self-injury, I get asked this a lot because we've seen an increase in this, especially in adolescent girls. Self-injury is different from suicidal thoughts. You can have kind of that Venn diagram of people who self-injure tend to be at higher risk for suicide. But self-injury in and of itself is another symptom. Typically, self-injury occurs when we have someone who's an internalizer, someone who doesn't act out when they're distressed, someone who's struggling with anxiety and depression. To help cope with that distress, will injure themselves instead of acting out. So they will cut, burn, things like that. And the whole place for self-injury, the tricky part is, when we talk to patients who have self-injured, they feel a slight respite or relief from the emotional distress they're feeling, because their attention has been diverted to the physical pain. And so in a way, it makes sense, where if someone's in acute mental distress, if they know that, hey, if I do the X behavior, my mind will be clear for a minute, or I won't be focused on it, it's hard to someone not want to have to do that again. And so when we're thinking about self-injury, I want you to conceptualize it as kind of a maladaptive coping mechanism versus true suicidal intent. Now and like I said, self-injury, there is a higher risk for suicidal thought, that they are not the exact same. They're not the same. So if we're looking at self-injury, I think the question I want to know, if I notice cuts on somebody, I want to ask, did you cut because you were trying to kill yourself? Or did you cut because you were just feeling really distressed? And, and try not to lead, but just kind of ask, see what they say. Look at the cuts themselves. So for example, if I have someone who's cutting on their wrists, or cutting on their forearms, I hate to say it, but I want to see if it's vertical or horizontal. I want to see how deep it is. Because if we're looking at a vertical cut, then I'm more worried about suicide attempt. If I'm looking at shallow horizontal cuts, lower away from the veins, we're looking at that more as self-injury. So I'm wanting to ask, learn more, and assess the severity of it. Is this consistent with more of a self-injury, especially in like the inner thighs and forearms, or could this have been a suicide attempt? Just like with suicidal thoughts, normalize self-injury as a symptom, Typically, that tends to be a symptom of depression with our adolescent females, but it could be anxiety or other ones. And then seeking professional help, just because we know that, we don't want someone cutting that, there are, scars, things like that. But there's always the chance that someone can self-injure and go too far. And and that can become that can be lethal or cause paralysis or things like that. And because we know that there is a higher risk for suicidal thoughts if someone has been self-injuring. So, ask, monitor, normalize, and then seek professional help with the self-injury. Okay, so lastly, I think this is my last slide. Hopefully I'm not running us over. Okay, low self-esteem. Really, when we think about low self-esteem, really wanting to reinforce when someone has done something well, or more importantly, taking steps to do something well. So not that they've done well at gymnastics practice, but that they paid attention and you saw them work a little harder. So reinforcing, providing that verbal reinforcement was genuine. The learned skill set, really helping them find some mastery in some area. I don't care if it's underwater basket weaving, it's gymnastics, it's something, but something that they feel like they have a special mastery of. If someone feels that, their risk of having low self-esteem goes down significantly. And then again, also helping make sure that we're always working on social skills, whether that's modeling social skills as a parent in front of them, helping with play dates, kind of giving the, hey, Timmy, I saw your friend just fell over there. What would be a good thing to do right now to be a good friend? Kind of cueing them. And then the peer support, so trying to help make sure that we're dedicating time not just to sports and academics, but also to social time as well. Okay, I'm really running us over, so I'm going to just keep this going. What can I do to help my child? I think your first step would be the pediatrician or school counselor. A lot of times they will have resources right away, especially if they might be in network. I hope you consider me, Little Dove. I love working with kiddos and would be happy to help. And if for anybody attending this meeting, I'm going to make sure to put my email in there. And if you have any questions about this or just want to be connected with resources, even if it's a psychologist that's in network, I'll be happy to help steer you to the right person, even if it's not me. So I want to make sure we get you evidence-based care. And the biggest thing is modeling those healthy lifestyle habits, modeling that you have good sleep hygiene, that you're talking about your body appropriately in front of your daughter in particular, that you're physically exercising and even saying like, oh, I feel really stressed, I'm gonna go for a run or whatever, just to model that, hey, physical activity is an important part of health and mental health. Resources, again, pediatrician, school counselor. The Texas Youth Helpline is really more for those crisis situations, or especially if we're having an unsafe environment. You have got my website here. In a crisis, we've got the 988 crisis line, and that's something I always want to make sure that my teens know about as well. It's a great resource. Okay, and I think I got us right to 6:59.
Awesome. I think everybody has the ability to unmute themselves if they have any questions for Dr. Kroll. Give you guys an opportunity to ask.
And I'm going to take off my obnoxious website here and stop sharing.
We definitely appreciate all of you participating. There are school counselors on every campus. We also have school-based therapists that are licensed on every campus. You have my name on the screen. You're welcome to email me if you have questions or you want to be connected to Dr. Kroll or other resources. We're happy to help. We'll linger for a few minutes in case anybody does have a question or wants to type something in the Q&A. But for those of you that are done, we thank you for your time and attention and have a great evening.
Yeah, I think one thing, if you do need to work with if you're trying to especially stay with somebody who's at network or local, when you look at their counseling page or their website, look for some of those evidence-based practices that I mentioned, because you really want to make sure that you're with somebody who doesn't just say they treat everything. We really want to make sure that they're providing evidence-based care. So again, your pediatrician can really help steer you to some good ones, as well as the school counselor. And then you've got my email if you want me to try to look through their bio as well. Okay,
Dr. Kroll, we did get a question in the Q&A. It's asking about any thoughts you may have about teen alcohol use. This person's saying they feel like it's even more prevalent with young as freshmen.
Oh, absolutely. Well, I think the biggest thing is, the function of the alcohol use. So if I have someone who's toying around with alcohol use, I want to, especially at a younger age, I'm wanting to see, okay, is it to escape their feelings and thoughts? Which has me more concerned for kind of potential alcohol abuse. And if so, we need to get into treatment for depression or anxiety or what's causing that. Or are they trying to fit in socially? And if that's okay, so then I would start having those talks about, again, those complex statements of, I don't agree with you using alcohol, but if you do, make sure you do not drive, or you have one beer, or whatever is socially acceptable. Or if that's not the place you're in, the child is 14, just talking about when it would be acceptable for them to use, and kind of the family values around that. But I think the biggest thing is always keeping an eye on what the function is for the alcohol. Is it the fitting in socially, or is it to mask feelings and emotions? Any data on when kids are starting to have sex? Unfortunately, I don't have that off the top of my head. I will say a lot of it depends on demographic variables. So if we're looking at kind of lower SES situations, we tend to see younger ages starting to have sex. I think we have a lot of, with low self-esteem. So families and communities that are more at risk because of different stressors, whether that's because of discrimination, poverty, we see lower, younger ages for having sex. So I don't have a good answer. It really depends on the child itself. But I think the key things I'm looking for when it's about how to prevent your child having sex a little bit too young. One thing I didn't mention is kind of the family's stance on modesty, and how they show how they take care of their body. So for example, in my family, it's a strong rule that that if you are getting changed, you're in the bathroom with the door closed. No one changes out there. We never would have a child shower with us. And starting and talking a lot about privacy and having the child step outside if you need to change. Not because there's anything inherent about, a 4-year-old saying mom or dad naked, but about going ahead and starting those practices early on about modesty, and that that you have privacy. And so really starting those conversations early. I think also the self-esteem piece is really key, of making sure that they have the higher self-esteem, so that they're not getting the attention because they're not getting it elsewhere. But I appreciate you guys attending today. I'll be happy to stay on a little bit more. I'm gonna keep my email in the chat. So if anybody has a question, or they just didn't want to bring to the group, or it comes to them later. And I always have questions once I've left the doctor's office. Y'all can just give me an email. I'll be happy to reply to those directly in the next day or two. I will say this would not be a consent for treatment, but I would be happy to talk about answer your question based on the research literature. All right. Can I say anything else, guys? Oh, thank you guys so much. All right. Thank you so much for taking your time to spend with me tonight. I hope y'all have a good rest of the evening and good into the school year. Take care.
Thanks, Dr. Kroll. I
Bye-bye.
appreciate it.
Mhm.